on right knee. And if we look to the after 24 hours, we have enterococcus faecalis methicillin resistant. And of course, it is resistant to the vancomycin, sensitive to the daptomycin and the linezolid. And how to root out infective endocarditis in these patients? First of all, what is the risk of metastasis or infected, including the heart in gram-positive infection? We have a high risk factor and low risk factor. First of all, what are the host factors? The host factor that if you have an implanted prosthesis, if you have IV drug abuser or history of endocarditis, is a high risk of metastasis. Features of bacteremia. The community-acquired MRSA is more serious than the hospital-acquired MRSA. The time to positivity less than 48 hours or more than 48 hours. The duration of the bacteremia more than 72 hours or less than 72 hours. The clinical course. We have a persistent fever, delayed start of antibiotics, sign of metastasis. All these factors put the patient on what's called high risk of metastasis. And recently there is a lot of scores, what's called risk stratification system, that try to combine all these factors in one score. And for example, one of these examples is what's called Vestra score. The Vestra score is a combination of factors like, for example, patient factor, community-acquired valve disease, cardiac disease, intravenous drug abuse, and embolism. Each one of them have a pointing system. And the species factors, like persistent bacteremia. And if we collect all these factors, and the recommendation is if all these points less than 2, don't do an echocardiography. No role of echocardiography in this particular patient. This is some useful scoring system that combine all these factors in one item. So in these patients, the second question, we have a patient of enterococcus faecalis. Do all gram-positive infection have the same risk to induce infective endocarditis or not? This is a very important question as well. If you look to this graph, we have an y-axis, the proportion of the patient with infective endocarditis. And on the x-axis, number of patients with bacteremia. If you look to here that for example, Staphylococcus and enterococcus faecalis, it is the highest percentage to induce infective endocarditis, followed by Staph aureus, followed by coagulated staph, and the least is the Streptococcus pneumonia. So Staph aureus, if the patient has a Staph aureus, definitely all the patient need an echocardiography. But if you have a Streptococcus pneumonia, some patients don't need echo if it is no risk factor of high risk of metastasis. This is very important that not all the species have the potential to induce infective endocarditis. So if you look to the stepwise approach how to do an investigation for patient with a gram-positive infection. If we have a risk stratification, either clinically or you have scoring or something or anything that stratifies the risk with the patient, the patient have not have a Staph aureus, negative risk stratification score, no other sign of infective endocarditis, you need to stop, don't do any further investigations. But if you have any one of these, you start by transthoracic echocardiography. Transthoracic echography, if it is negative and still you have negative risk stratification score and no other sign of infective endocarditis and the echo is of good quality, you still stop here and don't continue the pathway. But if any of this factor is not satisfied, you go to the transesophageal echo. And for transesophageal echo, if it is negative and there is no any suspicion of infective endocarditis, you stop. If there is still remaining any suspicious, you can go for a further investigation like through PTE or doing a PET CT scan. So this is the stepwise approach how to exclude the infective endocarditis from patient with gram-positive infection. So the last message is the risk of infective endocarditis in patients with a gram-positive bacteremia is variable. And use echo and other imaging modality should be individualized based on the type of the pathogens and patient-related risk factor. Thank you very much.